Today, we're fortunate to have Maningbe Keita from Johns Hopkins University discussing a project that she completed for CITM called Cost Effectiveness of a MRI First Approach versus Current Care for Diagnosing Stroke in Patients with Dizziness and Vertigo. It'll be a great session, so thank you all for joining us. Now we'll transition to the presentation portion of the session. I'm pleased to introduce Maningbe Keita. Mani is a PhD candidate at the Johns Hopkins Bloomberg School of Public Health in the Department of Health Policy and Management. Her research goals are aimed at improving health and economic outcomes for older adults and their caregivers, and ultimately to evoke equitable policy change. Within this framework, she's examining work productivity for caregivers of older adults and the cost effectiveness of initiatives aimed at reducing diagnostic errors among older adults. Welcome, Mani, and thank you for presenting today. We will now turn it over to you.
Hi, everyone. Can you hear me?
Yes, we can hear you.
Okay, great. Awesome. Everyone's muted, but I'm just going to check the attendee list to see who's on. There are some names I recognize and others who I don't recognize, but pleasure to meet you over GoToMeeting. I'm really excited to do this presentation, albeit a little bit nervous, but I'm excited nonetheless. So thank you for that wonderful introduction. As was mentioned, I'm a PhD student. I'm almost halfway done, and I'm especially excited about that. I'm in the Department of Health Policy and Management. I've been working with Dr. David Newman-Toker and with the Center for Diagnostic Excellence for a couple of years now, and I'll be presenting a short summary of a couple of the projects that we initiated. So since this is Journal Club, I thought I'd put a little bit of a spin on a standard scientific presentation and try and present it as a interesting story because it's definitely interesting. So without further ado, let's get started. All right, so welcome to the adventures of Diagnostic Dave and Measurement Mani. So today I would like to tell you a story in the long list of our adventures. For those of you who are wondering, yes, that is a picture of myself and David when we were doing some work around the VOG, trying to get that into a magazine. So, once upon a time, in a land far, far away, called the land of diagnostic excellence, there were two rulers. One was called the NIH, and the other one was called the Society to Improve Diagnosis in Medicine. So one day, Diagnostic Dave and Measurement Mani presented themselves to these rulers and asked for their blessing to slay a dragon that had plagued the land for quite some time. This dragon caused diagnostic errors left and right and led to some very serious concerns for patient safety. And this dragon also caused a serious increase in the cost of healthcare. Diagnostic Dave and Measurement Mani conducted some preliminary research and tried to make a pitch to the NIH and to CITM regarding the significance of their work. There are over 4 million United States emergency department visits per year for acute dizziness or vertigo at a cost of approximately $4 billion per year. The approximately 1 million cases with peripheral vestibular causes are overtested, misdiagnosed, and undertreated. Hundreds of millions of dollars are spent on brain imaging trying to rule out dangerous central vestibular causes such as stroke, yet 1/3 of vestibular strokes are missed initially. Current diagnostic care inappropriately relies largely on CT scans to differentiate between stroke and ear disorders, despite CT's low sensitivity for detecting acute ischemic stroke, which misses approximately 84 to 93% of posterior fossa infarctions. A more effective approach might be to obtain MRI scans in all dizziness and vertigo patients as a first diagnostic step. So we have dubbed this method MRI First. MRI has a much higher sensitivity than CT for identifying strokes, but the cost of an MRI is also higher than that of a CT scan. Thus, an understanding of the anticipated cost effectiveness of such an approach is essential before implementation. So by conducting a cost effectiveness analysis, Diagnostic Dave and Measurement Mani would be one step closer to slaying the diagnostic error dragon. The NIH and CITM rulers were convinced by their pitch and gave these diagnostic warriors their blessing and their money. And so their quest began. So in this project, we have the following methods. In order to do a cost effectiveness analysis, first you have to build a model. And this model helps you visualize the decisions that are made along certain pathways. So here we are interested in diagnostic decisions that lead to correct or incorrect diagnoses for patients presenting to the ED with acute dizziness or vertigo. And we're also interested in how those diagnostic decisions then lead to outcomes such as alive and well, disabled, or dead. So once we develop the decision tree model, we have to populate it with probabilities. Each decision or each pathway is associated with a certain probability. We also have to populate the model with costs. There are costs for all of the diagnostic strategies. We also populate the model with utilities. Once you are alive and well, there's a certain utility to being alive and well. If you are dead, there is no utility. And then ideally, once this model is populated with these data, we generate what's called an incremental cost effectiveness ratio. And that compares the costs and utilities of one pathway, in this case, current care, versus the next pathway, which is MRI First care. Our approach here is to consider what we call a base case scenario. In this scenario, we have a typical 65-year-old presenting to the ED with acute dizziness or vertigo of a neurovestibular cause. Our perspective is the payer perspective. When we're trying to advocate for the implementation of a certain method, oftentimes we have to consider those who are going to pay for the implementation of that method. Our time horizon here is 1 year, and we use the TreeAge program to conduct the data analysis. So here's a slide of our model. In this model, we're reflecting the diagnostic pathways of patients who present to the ED with acute dizziness or vertigo of suspected neurovestibular cause. So as you can see, you start out in the orange piece here, which is acute dizziness or vertigo, and then you are triaged into 2 buckets. So in truth, you either have a peripheral disease or a central disease. Then we have the next category, which is diagnostic accuracy. So you are then given a diagnosis which is correct or incorrect. And once you receive that diagnosis, we have an outcome, which is alive and well or healthy. We also have an outcome of disabled, and then our last outcome is dead. So we have a couple of model assumptions that we need to consider. We're restricting our cases to patients of neurovestibular causes of acute dizziness or vertigo. Here, the assumption is that there are certain patients who have dizziness along with medical conditions, but we're assuming that doctors are able to triage them out. It's only the neurovestibular cases that are of concern here. The peripheral diseases are placed into 3 categories. One is benign proximal positional vertigo, and the next one is vestibular neuritis, and the last one is Meniere's disease, bucketed with vestibular migraine and other ear conditions. We decided to place them into these 3 categories because these 3 buckets have distinct treatment pathways. Lastly, we also have a consideration for central diseases. The central diseases are placed into a single category, and that is because we assume that most strokes will fall into a central case. In some cases, we also have transient ischemic attacks as well, but these or brain hemorrhages, but these only rarely cause acute dizziness presentations, and they account for a small minority of cases. So the terms central and stroke are used interchangeably in this project. So for the model parameters, first we start out with our probabilities. Our model is here to the right, and as I stated before, each pathway is associated with a probability. In this project, we consider 3 different types of probabilities: disease prevalence, diagnostic accuracy, and outcome probability. Outcome probability refers to the probability of being alive and healthy, disabled or dead, given either a correct or incorrect diagnosis of the underlying disease. For the current care estimates of probabilities, we used studies of disease prevalence and diagnostic accuracy in dizziness and vertigo presentations. For the MRI estimates, we used studies of MRI diagnostic accuracy in suspected stroke patients. Where probability data were incomplete or missing, we used expert opinion to estimate parameters. Expert opinion was principally used to assign realistic lower and upper bounds for our parameters to create conservative model results. Next, we have our utilities. Our utilities are measured in what's called quality adjusted life years, or QALYs. So QALY is a generic measure of disease burden that accounts for both the quality and the quantity of life lived. It's commonly used in economic evaluation to assess the value for money of different interventions. Because our time horizon here is 1 year, 1 QALY equates to 1 year of health, and thus 1 is our max, our upper bound for QALYs. So when we consider QALYs, we have 3 different health states. We have dead, which we can reasonably assign a utility of 0. We have disabled and healthy, and these are assigned utility values based on literature-derived estimates for individual diseases. We use data from studies using SF12, EQ5D, and SF36 index scores to measure quality-adjusted life years. Lastly, we have our costs. Our costs generally fall into 3 buckets: neuroimaging, inpatient hospital admissions, and malpractice claims. So generally, we try to consider only costs that are likely to vary based on the diagnostic approach and the accuracy. Costs were assumed to equal the average reimbursement for a given diagnostic test, the average severity-specific hospitalization costs, or the average malpractice payment for a diagnostic error. These values were derived from the medical literature, and costs were assigned on a per-disease basis depending on the diagnostic test approach and whether the initial diagnosis was correct or not, accounting for return hospitalizations and malpractice claims for a subset of patients whose strokes were initially missed. All of our costs were adjusted to represent 2018 US dollars. For the analysis, we have what's called the base case. Our base case considers average values of the probabilities, the utilities, and the costs. In the base case, first we conduct what's called a rollback, which is when pathway probabilities are multiplied times each other to obtain the final probability of landing in a specific health state. Then we multiply all the pathway probabilities by the pathway costs, and multiply the pathway probabilities by the pathway utilities. Then all of the current care pathway costs are summed to derive the total cost of current care, likewise for MRI First care. And then all of the current care pathway utilities are summed to derive the total utility of current care. Next, we calculate the incremental cost effectiveness ratio, which is calculated as a ratio of the difference in costs over the difference in utility between the 2 care pathways, current care versus MRI First care. We also conducted what's called a Bayesian probabilistic sensitivity analysis. The goal of the PSA is to assess the impact of general model parameter uncertainty on overall cost effectiveness of the 2 strategies. Thinking back to our probabilities, utilities, and costs, you can assume that each value that we obtain from the literature has a certain level of uncertainty to it. So we've given lower and upper bounds to all of our values. In the PSA analysis, we consider a variety of values falling within these lower and upper bounds, and we vary these values for each node in our model, for each probability, for each cost, for each utility, and we conduct this 10,000 times in what are called Monte Carlo simulations in order to derive a new incremental cost effectiveness ratio that is based, that accounts for model uncertainty. In our Monte Carlo simulations, we have beta distributions for the probabilities and for the utilities, and then we have gamma distributions for the costs. Also, we have set our willingness to pay ratio at 100,000 US dollars. That's common in economic evaluation. So once we've calculated our incremental cost effectiveness ratio, if it falls below this threshold of $100,000, we can say that one method is cost effective relative to another. However, if the incremental cost effectiveness ratio is higher than this value, then one method is not cost effective relative to the next. So here are the results for our base case analysis for the ED. When we did our rollback, we saw that current care resulted in $2,650 for approximately 0.7134 QALYs. MRI First care costs more, but delivers slightly more QALYs. When we calculated the ICER, it resulted in $53,233 per QALY. And so we can say that the MRI First strategy is more cost effective by current standards. The figure on the right is what's called a one-way sensitivity analysis. So there are certain parameters in our model that are more or less likely to change model results. And here's what we've graphed. The one-way sensitivity analysis of key probability measures shows that the model is particularly sensitive to current diagnostic accuracy for stroke. That's the purple bar at the top, which determines the potential extent of quality benefits of the MRI First approach. The model is also sensitive to the probability of poor health outcomes given a correct stroke diagnosis. That's the blue bar. And the model is also sensitive to the probability of a central diagnosis, and that is the pink bar. Because MRI First provides no direct benefit in diagnosing specific peripheral disorders, it makes sense that the quality benefits mostly reflect quality benefits for stroke patients. As a result, it's not surprising that the ICER is largely insensitive to diagnostic accuracy for peripheral vestibular disorders. You can see that most of the variables in the graph on the right have to do with central illnesses. So when we run our probabilistic sensitivity analysis, here are the results. For current care, we have a result of $2,443.40 for approximately 0.7192 QALYs, whereas MRI First care is $2,844.74 for 0.7250 QALYs. However, when we calculate the incremental cost effectiveness ratio, we see that it falls way above our willingness to pay of $100,000 per QALY. So although MRI First care is slightly more effective than current care, when we account for model uncertainty, we cannot say that it's more cost effective than current care. So being the overachievers that they are, Diagnostic Dave and Measurement Monty were not satisfied with just applying this method to the emergency department setting. They insisted on also doing the same thing in the primary care setting. The primary care setting, although it's a different setting, we would apply a similar approach. And we would also apply similar methods. The only thing that would be different are the probabilities, costs, and utilities. In this case, we would now have probabilities associated with correct and incorrect diagnoses in the primary care setting. We would have diagnostic costs associated with the primary care setting and utilities. So they applied the same methods to the primary care settings, and here are the results. The principal finding was that the MRI First strategy for primary care patients with dizziness or vertigo is clearly more effective than current care, but it's not cost effective by societal standards at least. Here you can see that current care would lead to a cost of $1,145 for approximately 0.7028 QALYs, while MRI care would lead to $1,825 for approximately 0.7087 QALYs. On the right-hand side is a similar one-way sensitivity analysis, except for the primary care model. And it shows that this model is particularly sensitive to both current care and MRI diagnostic accuracy for stroke, which determines the potential extent of QALY benefit of MRI First. The model is also sensitive to stroke prevalence, as well as the probability of poor health outcomes given either a correct or incorrect stroke diagnosis. Because MRI First, again, provides no direct benefit in diagnosing specific peripheral disorders, it makes sense that QALY benefits mostly reflect quality benefits for stroke. Again, as a result, it's not surprising that the ICER is largely insensitive to diagnostic accuracy for peripheral disorders and mostly sensitive to central parameters. For the probabilistic sensitivity analysis results, we see almost no uncertainty in effectiveness. I'll call your attention to the figure on the right. It plots a distribution of the probabilistic sensitivity results, those 10,000 Monte Carlo iterations that we ran. The ICER for each iteration is plotted on this graph on the right. And then we take the mean ICER of that graph, and that becomes our ICER for the probabilistic sensitivity analysis. It's listed here at the bottom of the screen at $251,072 per QALY, and that is much, much higher than our willingness to pay of $100,000. So once again, MRI First care is not more cost effective than current care in the primary care setting. Some considerations. We can say that MRI First care is more effective in the ED and also cost effective in the ED. But when we think about model uncertainty, it may not be more cost effective. For the primary care setting, we can say that MRI First care is more effective, but not more cost effective, regardless of whether we're considering the base case analysis or the probabilistic sensitivity analysis. Based on the figures, we can see that the model is very sensitive to some uncertainty in our parameters. Also, regarding our costs, the model does not consider MRI capital movement, here meaning if a hospital does not have an MRI, it's going to cost a substantial amount of money to obtain one, to train people to use the MRI. We also don't consider potential indirect costs of ED care delays or delays in the primary care setting. So this bodes well for future adventures to consider resolving model uncertainty and to also potentially explore other diagnostic strategies which make use of the fact that MRI care is more effective, but maybe only employ it in a smarter setting or in a subsample of patients who are at high risk for stroke, so that we're also wisely using our economic resources. Thank you. That's my presentation. Let me know if you have any questions. I'd also like to thank the team at CITM for funding this work. And thank you to the Armstrong Institute Center for Diagnostic Excellence for the support while I was conducting this work. And a huge thank you to my adventure buddy, David Newman-Toker, who's provided support in many, many ways, and who has been there to answer smart questions and not smart questions that I asked, and who also really helped guide me through this process. I really, really appreciate it. Thank you.
Great. Thank you, Moni. We'll now open up the forum for any comments or questions. And you can feel free to either speak or to type in a comment or a question in the chat box. Moni, I had one question, which is, in the executive summary, you had also reported on the results for patients that were considered to be high risk. I was wondering if you could speak more about that and what exactly, or how exactly you defined patients as being more at high risk.
Yeah, so this, I only gave a short summary because we had about 15 minutes for this, but we did conduct a series of sub-analysis for the project. And
this conference will now be recorded.
For one of them, one of our projects was to consider a subsample of patients who are at high risk for stroke. These are patients with acute vestibular syndrome. And we found that MRI care can be cost effective in this subset of patients. So I think that bodes well for some of the work that David is doing on the VOG method, which tries to, for lack of a better term, wisely triage patients into different risk buckets. So if we can categorize patients into high risk versus low risk, then perhaps we can advocate for using MRI First in high risk patients so that we can quickly identify those strokes. But it really doesn't make sense, in my opinion, to use an MRI on everybody.
Great, thank you.
I can also talk about all the problems we ran into if anybody wants to know.
Just sort of thinking about future analyses, if you were interested in sort of incorporating how startup costs would affect this analysis, how would you go into looking into that? So I imagine that obviously this would be more of a burden for smaller hospitals or communities that have fewer MRIs to sort of get those facilities up to standards.
Right.
How could you incorporate that or into the analysis?
So I think that there are two pieces to that approach. So the first part is just how are we going to incorporate this period, and the second part is how are we going to interpret those types of results. So as you said, it is more likely to affect the smaller hospitals, maybe community hospitals or rural hospitals who have less resources. So I definitely would reframe the model to pertain more to smaller hospitals, and perhaps I would look for information on the cost of an MRI and on the average cost of training for large transitions. You can kind of think of a couple years ago when we transitioned to Epic. I'm sure that there's data somewhere in somebody's office about how much that costs on a grand scale, but hopefully for smaller hospitals it would cost less as they have less personnel. And then I would probably calculate those costs separate and not immediately put them into the model because the model calculates costs per patient, and it really doesn't make sense to repeat implementation costs for each patient unless you're trying to think of like an initial transition phase. But I'd probably present those costs in a table as a separate analysis. And then in terms of advocating for a transition to either an MRI strategy or the VOG strategy, which smartly uses the MRI, I would really try and show hospitals what the cost savings would be down the line. They would be responsible for a large amount of upfront costs. Sorry, it's a little hard to hear. Somebody could just mute.
Or could mute themselves, that would be great.
Yeah, so as far as advocating for hospitals to take on this high initial costs of implementation, I would really try and present the final results in terms of downstream cost savings. So we can see that you gain additional QALYs, and even though those QALYs are very small, on the order of tenths or hundredths of a value, when you multiply them by the 1 million stroke patients or by the 4 million patients who come in for acute dizziness and vertigo, it really does add up. So that's kind of how I would approach the future analyses and the translation of findings.
Great, thank you. We have a question from Io who says, who asks, do you believe your work can be used to empower patients? If so, how?
Well, that's a good question. I do think that my work, our work, can be used to empower patients, although the main approach of this work has been to really advocate for payers, insurance parties, and whoever's paying for these services to take on this transition. I think it's important for patients to be aware of these different diagnostic strategies. Ideally, we wouldn't just be translating findings to hospital administrators, but also to patient advocacy groups. And hopefully, as they educate themselves on the different strategies that there are to reduce diagnostic errors, they can then advocate for these strategies. We know that money talks, but also the public talks, and it's important to garner as many different stakeholders as possible. And hopefully patients can advocate for, well, maybe not an MRI every time they walk through the door, but ideally a VOG.
This is David. Great presentation, Molly. Wonderful. I have two questions for you. The first is about young patients. So you have your base case model assumes an average 65-year-old. Could you talk a little bit about the ramifications of thinking about this for young people who are much less likely to have stroke, but who are much more likely to be misdiagnosed? How you think that might play out conceptually?
Right. So I think that when it comes to reframing the model and reframing the perspective to consider younger people, as you said, they are less likely to have stroke, but if they're more likely to be misdiagnosed, we can think that this may have really great impact for quality adjusted life years. So our current time horizon was just 1 year, and that's because the base case is older. But if you were to take someone like myself, for example, who's in their 20s, to society, I have a certain number of years that I can contribute. But if I am misdiagnosed at an earlier age, that limits the number of years of productivity that I can add to society. So you could even say that the ramifications are even larger, especially from a human capital approach. So we definitely don't want young people to be misdiagnosed, but that would definitely be an interesting sub-analysis to make, just to be able to quantify the amount of utility that's lost when a younger person is misdiagnosed. I think that would be very, very interesting.
And the other question is about the perspective. So you took, remind me, was it the payer perspective?
Yeah, the payer perspective.
So could you talk a little bit about the ramifications of that decision vis-a-vis any a hospital implementation versus implementation and payment by an insurance company versus the societal perspective? You have any thoughts about that?
Yeah, so most commonly when you conduct economic evaluations, you do what's called the societal perspective, which considers anybody and everybody, and you throw everything you can into the kitchen sink. And it's an important perspective because it really forces you to try and consider all potential costs. So just as an example, if I take my aunt or uncle, let's say I take my grandmother to the ED and she is misdiagnosed. She has acute dizziness and vertigo, and she is misdiagnosed and she has a stroke. In this project, I only considered the immediate diagnostic costs, but if I were trying to consider the societal perspective, one could argue that there's also a cost in terms of the time that it took me to go to the hospital, the time that I wasted while I was in the hospital with my grandmother, i.e. I could have been at work generating income. Because she had a diagnostic error, that's additional time wasted. Perhaps I then have to take off more time from work. So there's a long list of possibilities in terms of the downstream costs that you can calculate. I think it's important that we specifically focused on the payer perspective here because we have an implementation goal in mind. So when we're considering these large hospital transitions or large systems transitions, we have to understand who is going to pay for it and what are the costs that they are more likely to incur, because that is the type of perspective that they themselves are using when they read your results and your findings. It's sad to say, but if I just presented costs to the patients, to an insurance company, they may or may not be moved. But if I was able to articulate that this is going to cost you, the insurance company, or you, the hospital administrator, a significant amount of money, then they're more likely to move their feet. So that's why I think it's more important to consider the payer perspective when you're doing economic evaluations, but it doesn't hurt to run both, just in case.
Thank you. That's super helpful.
You're welcome.
Are there any other questions or comments that folks have? Okay, if there are no further comments, then we will go ahead and close out the session. Monty, thank you very much, and for everyone else for joining us today. Our next journal club is going to be held in June. We will send out notifications about the date, and we look forward to seeing everyone then.
Thank you.
Thank you.